We have heard a lot about it within the industry recently, and we've also seen great things happen when it's executed well. So diving right in, we're going to be talking about a few different things today. Really just talking about why multidisciplinary rounding is important, as well as how to get everybody on board, and also just how to maintain that momentum once it is implemented. So my name is Katie Anthony. I'm the marketing coordinator and your host for today at MyRounding. I have a background in a wide variety of marketing items and in the technology and healthcare field. I also have Chad Kellogg and Steve Bachtel with me today. Chad and Steve, would you like to introduce yourselves?
Steve Bachtel, I'm with MyRounding. Thanks very much for joining us today. But Chad and I will be running through this agenda for you today on multidisciplinary rounding and multidisciplinary care coordination. It was interesting the way we landed on this. Huron has, for a very long time, coached on interdisciplinary care coordination, and when we joined forces, MyRounding was doing a lot around rounding, and we discovered that the MyRounding tool could very easily support the rounding that Huron was doing. So, Chad, I'll go ahead and let you introduce yourself as well, and then we can jump right in.
Sure, thanks, Steve. Yeah, my name is Chad Kellogg, and I've been in the healthcare industry for about 16 years, specifically working on interdisciplinary care coordination implementations over the last 12 years. Probably implemented at approximately 20 different clients across the country, ranging from large academic medical centers, health systems, to even small community hospitals. I mean, the applicability of multidisciplinary care coordination rounds is really in any care setting.
All right, so we wanted to start at the very top, at the beginning, and really the definition of multidisciplinary care coordination. So as you read that, I've been doing a little bit of research, and there's some really great results, of course, and this has been around for a while. So for the past couple of decades, honestly, multidisciplinary care coordination has been around. So there's really great findings out there. The Journal of General Internal Medicine back from 2007 did some research with Norwalk Hospital. So this is an affiliation with Yale University and Albert Einstein College of Medicine. And through multidisciplinary rounding, they saw significant improvement in core measure quality. They saw at this particular hospital, which was about a 400-bed hospital, saw an 11% lift in CHF outcomes, a 7% lift in AMI outcomes, a 43% lift in pneumonia. I think they also reduced length of stay by half a day through this type of rounding. What was really interesting to me that came out of this was the educational component. This was a teaching hospital, so residents reported substantial improvements in core measure knowledge. So that was something I hadn't considered a whole lot, and I know Chad has talked to us about it before, but the fact that from an educational standpoint, whether it's knowledge around core measures or evidence-based care or systems-based care, the residents reported that they learned a lot through this process. So even beyond the outcomes, there was lots of knowledge transfer. What I also found interesting is looking at a review of literature, so 51 different papers that were reviewed. When they identified what most needed to be improved, the researchers found that it was process-oriented information tools. So this was literally what tools could we put in place to help organize the information, organize the round, and improve the workflow. And specifically, they were looking for displays or printouts or at-a-glance representations of unit performance. And that's one of the things that we'll talk about today. I think it's one of the things that we can certainly provide. Lastly, though, what was needed to maintain? One of the really key factors that I think you'll find coming out of this webinar is if you want to maintain the process, if you want to maintain your momentum, the literature says that you need a quality rounding checklist or a quality review of your rounds. So first you develop the round, then you create a quality review, and we'll talk about how to do that today. So why is this so important? So Chad, we know that we can see a lift in a variety of areas. Why don't you tell us a little bit about your experience?
Sure, Steve. So, we have listed there some of the things that the MCC does improve, and when we talk about safety, it really gives the care team the opportunity on a daily basis to make sure everybody's aware of the safety precautions of the patients and what needs to be done with those specific targeted patients. You know, when we talk about quality and consistency of care, really getting the entire care team on the same page every day drives a lot of that consistency of care and leads to quality outcomes. Proactive patient care planning, again, really planning for the day and for the stay, and doing that right from the very beginning, doing that upon admission to make sure everybody's on track with where at least the care plan's headed, knowing that it can change and probably will change, especially on medicine units, but ensuring that everybody's being as proactive as possible to removing those barriers to get the patient discharged in a timely manner when they're medically ready. Patient satisfaction. We see time and time again that without even really focusing on patient satisfaction, we'll see improvements in HCAHPS scores, especially things along the lines of communication with nurses, communication with doctors, discharge information, talking about the care transition, and even having a lift in recommending that hospital. And again, that's with no focus on the patient satisfaction. If you take that to another level and add in specific talking points and things like that, you can really impact patient satisfaction in a big way. And then finally, care team efficiency and collaboration. It can really reduce the number of interruptions throughout the day, and that's where we really talk about the efficiency component. Everybody getting all the information at one time. They're not having to chase it down, or they're not being interrupted through the day, and it really brings a more collaborative approach to that care plan. You know, caring for a patient is just not one discipline. It really does take a care team, and getting everybody's input at the same time really helps drive a better care plan. You know, on the other side of the slide, you have what it reduces, and so admission and discharge wait times. Again, practically planning for that from the very beginning, and making sure that discharge happens in a timely manner can help the admission process, free that bed up earlier in the day, get the next patient that's waiting for the bed in there earlier, and getting the patient that's ready to discharge out on time. You hear stories all the time about the patients that are ready to discharge at 8 o'clock in the morning. They end up not leaving until 5 o'clock that night. Well, that's a long time to be sitting there when they don't need to be taken up a bed. The reactive discharge, the reactive transition planning, scrambling around at last minute to really make sure all the discharge plans are buttoned up and ready to go. And so getting those done earlier in the stay, making sure that you're planning for it, making sure that you're communicating it with the patient so that when they are ready to go, it isn't the last minute scramble that so often has to happen. And then finally, avoidable days. So Steve mentioned a little bit about the reduction in length of stay, but you know, a lot of avoidable days are attributed to not really planning appropriately in the stay. And so having that care team around the table, having the proactive plan, and making sure that the patient's discharging when medically ready, you are avoiding the days that otherwise they would be staying in the hospital that are unnecessary.
So Chad, I know you talked about that patient has been waiting to go home for the better part of a day, and I know that we have a customer that we were recently working with who started collecting data around why people why there were delays. So they were measuring this rounding. One of the things that they found was there was a shift change in the pharmacy. So in the afternoon, there was a shift change, and patients were waiting for medications to come. And because of that shift change, they literally were adding almost 2 hours to the process because they had to, the new pharmacist would come on, they'd have to get up to speed with what was still needed to be filled. And that was a 2-hour delay that created further delays for the patient, the patient being able to go home. So that is just a great example of why you really need to measure this. So it's maybe also a good segue into our next component, which is what makes multidisciplinary care coordination and rounding effective. So Chad, we're kind of sold on multidisciplinary rounding. What do we do to make sure that it's effective?
Sure. You know, Steve, you mentioned that the concept's been around for decades. And you even will talk to even some older physicians, for example, that will say, oh, we used to do this when I just came out of residency, 20, 30 years ago. So it's not a new concept. But the real key is, how do we make them effective? They can be in place, but they may not be very effective. And so some of the things that we typically see that drive that effectiveness is the consistent daily meeting with care team members. So it's every day. It's not once a week. It's not only on the weekdays and not on the weekends, but it's every single day at the same time.
And I think you said that you've seen organizations that have tried to do it where they weren't consistent, and it wasn't terribly successful.
Yeah, it even becomes more difficult because sometimes multiple care team members have to go across units. They have to take care of patients across units, and you have a unit or units that are not doing this consistently on the same day. It gets very confusing for them, but if they know the times on each unit and they know the day that should be every single day, it makes it a lot easier process to build into their workday versus trying to figure out their workday along when these are happening on units that they're having to cross over based on where their patients are. So it's one of the key things is definitely a consistent daily meeting. Clearly defined roles for the participants. We often see that sometimes the meetings that struggle on this, people are showing up and not really knowing what to talk about, what information to be bringing, what's the purpose of this meeting in the first place. It may have started out as something very targeted, but over time, and we'll get into this in the quality review process, but over time it's morphed into something else that the care team really doesn't know what to bring to the table because the conversation may change every single day. So clearly defined roles about what they're bringing to the table and what they're expected to discuss and how they're expected to contribute is key.
So it sounds like you have to make owners of each member of the team. So if I've got a provider coming, I've got a physician coming, I've got to make sure that physician knows what they're there for and what we're asking them to present.
Absolutely, and it clarifies what people are supposed to bring. It clarifies when topics are starting to get off discussion. You need to have those discussions. They may need to still have them, but not in the meeting. And so it really does help bring an effectiveness to the meeting and efficiency to the meeting. And that goes into the other comment about brief and focused discussion points. You really do have to, this is a 1 to 2 minute discussion per patient. This is not a whole history, let's talk about every stay they've had or everything they've done for this day. It's really focused on what do we need to do to move the treatment plan a day, and what do we need to move this forward, move the patient forward towards discharge. And that's key. It should be brief and focused and targeted and get it from all the care team members so you have the right plan and then can move forward and execute on that.
And we're going to talk a little bit later, but I'm going to jump the gun because that quality review, so this is like an audit, right? So this is another person in the group that's going to sit and make sure that these are brief and pithy. I imagine that if it starts to drag on, the first thing you're going to have is physicians leaving the group. Maybe some of your specialists are also going to bail because they don't have time for that.
Yeah, absolutely. I think what I've seen is almost nothing destroys this meeting concept faster than the meeting starting late or the meeting running longer than what people have expected in their day. It really becomes that it's not adding as much value to them as what they needed to at that point. It's taking more time away from their day, which makes it even a more struggle for them to complete their other responsibilities that they have. And so you're exactly right. It has to be to the point, brief, and get in and get out. A big piece is identify the expected discharge date for each patient. Again, that proactive planning component. Upon admission, do we have a target date that we're looking at and the care team is agreeing to, and then have a plan to get there? It's not just important to say, yeah, the patient's going to leave in 3 days. Okay, that's great. What do we need to do each day to really get them there to make sure that we're getting them out? The care plan can change. The expected discharge date will change for a lot of patients, and that's expected. It's a lot about how the communication is to the patient so they understand that, but you have to start with a date in mind and drive towards that, or the care team doesn't really know where they need to be doing it and what sequence they need to really be working in.
Yeah, and I seem to remember a story about some staff members who are really kind of hesitant to set a discharge date, or at least communicate a discharge date to a patient, really fearful that they might miss it.
Absolutely, we hear it all the time that they believe that the date changes so much that they think they cause more issues with the patient and the expectations when they constantly have to change the discharge date.
Is that true?
I think so. I
okay.
think, well, it's true to the point that they're not communicating in the right way. So
right.
it's
I think,
the right expectation.
Yeah, I think what all of the literature says and what we've certainly found in our research is that you can definitely say this is your expected discharge date, but as long as you're keeping the lines of communication open, telling them kind of what's happening, patients will always understand if it has to be longer because you've identified new things, or of course if it's shorter, hey, even better.
Yeah, and to the point is
it's all about communication, really.
It's all about expectation. What has to happen to meet that discharge date, and if we're not able to accomplish those things, then that date will change. Okay. Or if we're able to accomplish them faster, then that date will change. But setting that expectation right up front.
Yeah, tell us about assigned follow-up, because this was the other thing I think that the literature said is, being able to, a lot of times people aren't following up.
Right. So you bring this care team together, you decide on an action plan, everybody goes off and does their own things, and they're not following up on what they agreed to, or there's no loop back channel. And so a key piece of that meeting is decide on action items. People go out and execute against that and make sure that it's happening so that the care plan is moving along. And if action items are not being assigned up, then it's just a bunch of people getting together and not really driving the care plan.
And how do you see these typically being assigned? So right now, if we don't have technology in place, how do you assign those to make sure people are following up?
A lot of times when we put in a process, it's a paper process, which that's what we've done in the past, where you create almost a log, and that's cumbersome, where the facilitator's trying to document the action item follow-ups as they go along, and it's a little bit clunky to follow up, but that is a form they can do.
Sure.
With some of the new tools, especially like MyRounding, you have an electronic way to do that, and also can really drive has the care team followed up, who has open assignment follow-up items, and where do I need to really follow up as the owner of the meeting.
Yeah, this came up a lot in the literature as well, is that lack of follow-up to what was identified during the round. And most of the studies said it's important to identify a tool to hold everybody accountable to what they've promised.
Absolutely. And then, Steve, you mentioned this in the very beginning, but the quality review process. This is one of the things that we actually see missing the most if we come into a hospital that has these rounds in place, that there's no quality review process. And like I said earlier, what the intent of the meeting, what the intent of the design and the implementation of the meeting was 5, 6, 7 years ago, can often morph into something that has become very dysfunctional, not effective. Maybe the facilitators have changed multiple times, whatever the case may be, and there's no feedback mechanism on how the meeting's doing. Is it staying to how we designed it? And missing an educational opportunity with the care team to say, this is how this meeting is performing. These are the items that we really need to focus on to get this back on track. And
yeah, and I'd be willing to bet that some of the folks listening right now probably already have a process in place, and maybe they're trying to repair a process. Maybe it's a process that, like you said, has fallen apart. I tell you, I wish we could take this quality review process and just blow it up on the screen, because what I've really learned from this is that kind of slide after slide, this becomes a real linchpin to maintaining momentum with this process. I think that ties in pretty nicely to our next slide, which is how do I get my boss or team on board. So maybe it's either getting them on board, or maybe you're trying to re-get them on board. And I think we've got some important points here. So let's walk through this, Chad.
Yeah, so one of the things that's always important in having any type of discussion about this meeting is that you're making sure that you're keeping the patient in the center for all the discussions, and why it's important to get the whole care team around this. And if it's not functioning well, how do we bring it back together again for the best outcome for the patient? And as long as I think you're talking from that viewpoint, it's typically easy people are not going to, especially care team members, are not going to argue against that point.
Yeah,
absolutely. Being inclusive in the design process is critical. Because there are so many different care team members that really should be a part of this meeting with different schedules, different priorities, different duties, having them in the design process really gives the meeting a good chance to get off to the right start, or get them there to participate. There is no perfect design for these meetings, meaning there's no time of the day that's going to meet everybody's perfect schedule. It will never happen. What you're really doing is picking, honestly, the best of the worst, and trying to just make it work for the best of everybody, and that's really what you're going to be going for. Finding champions, I talked a little bit about the physicians, and I was smiling about them. When you find a physician that really sees the value in this, really use that physician champion. It doesn't have to be an elected leader in the organization, but really use that physician champion to communicate the impact that it's having to his day, and get the other physicians to try and be engaged in this process, because it really can make a big impact in their day and how they function, how they and how they relate with the care team.
And when you think about setting this up, do you ever start in say one department? Or I know a lot of times we do this. We'll look for that kind of one perhaps as a progressive, really well performing department where this will probably stick. Do you guys ever do that?
Yeah, we've done it in so many different ways, Steve. Usually what we try to do is more of the Big Bang Theory, get all the units kind of up and running, or do it in a couple different phases. But we've worked with a lot of organizations that want to do the one unit, want to showcase demonstrate the outcome, and not only care team collaboration and get some good quotes about why it's important to their day, but also you start to see the benefit in the quality, safety, and then also the avoidable days component too, and so that drives that. So it's a good way to start. You can definitely do one unit. You just don't want to be a little bit cautious of how long it's going to take you to get the all. I mean, if you're in a big academic medical center with 24 units, doing one unit at a time is going to take you a long time.
It will. You're right.
So just want to be careful about that. We have solicit input. Again, it goes into being inclusive, but again, making sure you're listening to that input when you're designing this. Just don't force something through the gate. Try to be as accommodating as possible, but knowing that you're going to have to accommodate care team members across the organization to really make this work. HCAHPS opportunities. I think I talked a little bit about this earlier, but can be a big driver. If your HCAHPS scores are low in some of the key categories, especially around discharge, this can be a big emphasis to say, we've seen this. You read the research, it's out there. You look at that and you say, look, this can be a big way to make sure that we impact the satisfaction of our patients in a very positive way, and we'll see the outcome in our scores. Focus the messaging. So really keeping that clear and concise about what you want to do, why you're doing this, how you're doing this, keeping the patient in the middle, so that the care team members know exactly what the purpose of this and why they're going after it, is key. Set metrics-based goals. So you talked a little about this in the beginning, Steve, but from the very beginning, what are you trying to accomplish from a metric-based goal? Is it to reduce avoidable days? Is it to increase patient satisfaction? Is it both? It should be both, really. But set those goals up front so you can measure to improve as you go along, and you can see if what you're doing is really impacting that, and then report out on that. That should be a very positive, once you implement this, you do this right, you should see your improvement there, and then you can communicate that to the hospital, the physicians, whatever the case may be. So if it starts going off track, you can bring people back to, yes, but look at what we've been able to achieve in this time period.
Right.
And then to measure and communicate, I kind of covered that with that one, but when you do achieve that, make sure you're communicating out what the results are so people don't lose track of why you're doing this.
Yeah, and around the measure and communicate, what's neat about this, I think, is that technology has sped up in recent years. So we are starting to at least have technologies that would allow you to measure this and perhaps even communicate out. Great. All right, so I think moving on. So we've talked about how to be effective, how to get the team on board. I think the next one is just really the nuts and bolts of how do we implement this. So Chad, what's your advice for implementation?
Sure. Again, I think I talked a little bit up front about the concept is not rocket science, but getting this in the right way is difficult. There's a lot of different variables here, and so obviously getting agreement upon the care team member participation up front. This is key. In our opinion, you want the bedside nurse, you want the physicians, you want the care manager, social work, depending on what units you're talking about targeting PTOT. So it's really important to get agreement on the care participation meeting up front, especially as you're doing this across multiple units, and keeping that in mind that some of these members might have to float between different units, and so you want to make sure that they're not having to decide which unit they need to go to at that point. Hopefully you can stagger them, and if not, put in a process where they are identifying the right meeting to attend. Agree upon a meeting place and time. We covered this a little bit earlier too, but it's that consistency. The meeting place should be one location, same location every day. The time should be the same time every single day.
Is there a common time and place
Sure.
in your experience?
Not so much a common place. Up on a unit is obviously the best place for it, finding a place up there. Sometimes that's difficult, but there's usually a break room or something like that this can happen in. The time we usually look for in the morning, really trying to make sure that you set up the day right and go from there. However, every once in a while, because of schedules, especially even on surgical units where the physicians are operating all morning, sometimes we do have to look at a later in the meeting, a 2 o'clock meeting or a 3 o'clock meeting. The importance, if that happens, that you're going to even have to be more proactive in your planning and in your communication, because you're kind of always at that point the day is gone, so you're kind of always talking almost a day or 2 days out at that point.
Sure. Is there a good candidate for facilitator?
What we do is we look for facilitators that's going to be there 7 days a week, and that makes it difficult, right? A lot of times care managers are the facilitators of this meeting, but they're not there on the weekends. And so that means it's a different weekend structure that you have to put in place. So we do look for typically a nurse facilitator of this meeting. Charge nurse is typically what we look at. However, that being said, I think what the important piece is there that you find a facilitator that is going to at least be there to cover the most of the days. Sometimes charge nurses are a little bit tough; they're in ratio, and so it's hard to pull them out to facilitate this meeting. But really look for consistency in the facilitator. Don't have a care manager be a facilitator in one unit, a nurse be a facilitator in another unit, a physician be a facilitator in another unit. I think that causes a lot of confusion, and the training and consistency gets a lot harder. So it's important to identify one position in the organization that does a facilitation of this meeting, so the same expectations are set across the units.
Yeah, and then you move on to training sessions. So
yeah.
What are we training?
So, you know, a lot of and I think people have probably seen this, if they've been in a hospital a long time, a lot of times if you're very good at your particular area of expertise, it doesn't mean that you're automatically going to be a good facilitator of a meeting. So it's important to spend some time coaching and training on how to facilitate the meeting, how to make sure you start on time, pull the information from the care team members that you need. If they're not presenting it, it's being pulled from them to make sure that the discussion is happening, drive that the critical thinking is happening about the care plan, and people aren't just nodding their head and saying yes and moving on to the next patient without really appropriately challenging each other in that forum to collaborate to get to the best outcome and just not agreeing to. So that's the importance of the training. It is important to train the care team members that are going to show up very briefly, but most of the training can be done during the meeting itself when the forum gets set up and it gets moving forward.
So we've done all of our pre-work, and now it's time to go live. So from a go live standpoint, you say timing is crucial. What does that mean?
Yeah, so we talked a little bit about this in the last slide as far as, I mean, typically time of day, yeah. Right? But the other part is that it starts on time and ends on time. When we say timing is crucial, again, you start delaying the time that it gets started. People will start expecting that. They'll start showing up late, knowing that you're going to start late. And here we go with expanding the meeting out past when it's really useful. And it happens very quickly. So timing is not only important from the time of day, but from getting it started on time.
Yeah, and then follow-up is the next one. And again, back in the research, a lot of the studies that they did said that they needed some sort of tool that would allow them to assign follow-ups and then hold people accountable to those follow-ups, which is sometimes tough to do, perhaps unless you have some technology to do it.
Absolutely.
And then manage participation?
Yeah, so again, it's talking a little bit about getting the information from the care team if they're not providing it. Hopefully over time the care team knows what to do when they show up, they talk about, but again, with new people coming in the organization, there's always this constant training that's going on so that people really know what to bring to the meeting. And so you're helping to manage that. You're helping to pull the information in. Also, if you're not getting participation from a particular care team member on a consistent basis, going to have that discussion with that department head so that you can secure that again, or what's changed, why they're all of a sudden not showing up and they used to, or whatever the case may be, or you got agreement on it and they're not meeting their agreement because it leaves a gap in the care team.
Yeah, and I know when you had us build a template that helped kind of manage this meeting. So we built the template within our technology, and we had a checklist, in this case, of all the people who were supposed to attend, and you can check the box that says, basically it's an attendance record. And I guess the nice thing about that is then you have a report on the back end that says consistently you've got one member who's not coming.
Right.
And then when we talked earlier about having a champion, well, now it's time to pull that champion in and say, hey, I've got a report here that says so-and-so hasn't been making it.
Yep.
Could they help kind of push things along?
Absolutely.
Right. So clarifying confusing topics, when do you get confused during this meeting?
Well, I mean, the care plans are always, they take a lot of input for that, and making sure that as people are bringing information to the table, if there's any confusion, that you are clarifying that. For example, one of the most clarifying is the specific follow-up that needs to happen out of that. So there's not confusion among the care team about who's going to do what next. But also really challenging the team to critically think through the care plan. And this kind of goes to the evaluate the care plan, but don't just take, whatever one care team member says is going to happen. Don't just leave that. I mean, if somebody has a thought or input about how to do something more effectively, efficiently, that should be discussed in that meeting so that if there's agreement, everybody understands what's going to happen.
And that's where those residents were talking about, that going through this process, they learned a lot about evidence-based care. They learned a lot about standards-based care because there was someone in the room who was able to tell them what that standard was.
Absolutely.
So that's great.
Absolutely.
And I assume review and summarize. If we were clarifying confusing topics, that summarization is always nice to come back and just kind of touch base with everybody. Make sure everybody understands what we just discussed, understands what the takeaways are. Raise your hand now because you're going to be expected to follow up later.
Right. Hey, right on.
Okay.
Now, real quick, before we jump into that, we have a question that came in, and that is to talk around the difference between rounding at the bedside versus in a conference room or out in the hall or another area.
Sure. So, patient rounding is definitely been a topic for around a long time. It especially happens in children's hospitals is a prime example of this. And so, when we're talking about this and we're talking about multidisciplinary care coordination, we really are looking at the 1 to 2 minute quick discussion. We're not saying you should get rid of the patient, the bedside rounding. We think that can be a very important aspect of the care. And the problem that we run into with the bedside rounding is it can take a lot of time on a large unit, 24-bed unit. It can take a lot of time. And to really have a care team member, like a care manager, go through all that and then try to get through all their other responsibilities is tough. So we still think this is an important meeting to have, get through it quickly, and that it shouldn't just automatically take away the patient. But you do have to look at what topics are being discussed in each one and make sure there's not huge overlap, or if there is overlap, what makes sense for the overlap, and make sure that that's being communicated back to the patient.
Sure. Yeah, and of course we also kind of break it out. Remember, this is what we're talking about today is really a team coordination meeting. Mm-hmm. So this is all of the disciplines together talking about each of the patients with the patient absent. We want to find out, what do we have to take care of today to make sure the patient can go home when expected. That's very different than around with a patient to make sure that we're taking care of the patient well, or perhaps a bedside shift change. Where we're talking about kind of what we've done so far in front of the patient, so the patient's part of that communication.
And our teaching rounds, obviously, in a teaching hospital, that function is not going to go away because you have this multidisciplinary care coordination meeting. But how do you take the key components and make sure that the whole care team's on? Because most likely the entire care team's not going to be able to go with the teaching rounding.
Right.
Bedside rounding.
So lastly, we move on to how do we maintain momentum, and I tried to stress it up at the top, but all of the research, all of the literature that's out there right now, and then also I think, Chad, you said your experience has been you've got to do that quality review and have some sort of audit. I'm sorry, I'm here. That quality review becomes really important.
Yeah, it's one of the best ways. I think it's one of the best ways to keep leadership engaged in this process, the C-suite engaged in this process, so that the care team really does feel the importance of this meeting. Even if they didn't already feel the importance of it, probably something's a little bit wrong with the efficiency or effectiveness of the meeting. But if they ever had a doubt and you have one of the leaders of the organization, CNO, CMO, it could be even nurse directors from other units, whatever the case may be, doing the quality reviews, they are continually reinforced that this is an important process and it needs to stay and it needs to happen in a good way. But not only that, it gives the opportunity for the leadership team to interact with the care team, really know what's going on, and then provide feedback based on objective criteria to say this is an area where we could have done better this meeting. But then you can look at it over time to see where maybe there's maybe something bigger needs to happen from a training and education component. So you not only have the feedback that day, but then you look at trends over time to see if there's something more that you need to do house-wide or for a specific unit to really focus on one aspect of it.
Yeah, and this is one of the first things that you asked us to build was a template that would allow you to do that audit and make sure that this is going well. And it sounds like the folks that are on the phone right now, many of them are perhaps trying to re-energize this process or improve this process, and this might be a very helpful tool for them because then they'll be able to truly track what's happening. Is it starting on time? Is it ending on time? And kind of start anew. But then, hopefully, after a series of weeks or maybe a month, you'll start to have some really nice data that tells you here are the pockets where we're struggling and they need some more training. Here are the pockets where they're really excelling. So that's great. Well, I think with that, we are all done. Thanks everyone for joining us. We hope that this was beneficial for you. We're going to leave the line open for a little bit in case there are some questions. We've got our chat window open, so Chad and I and Katie are here to answer any questions that you might have. We'll sit and watch this chat box. Also, I would absolutely encourage you to download the ebook that comes along with this. Katie, how can they do that?
That is available on MyRounding.com. It's part of our resource library. There's also a lot of different ebooks and other resources in there about different healthcare topics as well, anything from HCAPs to different rounding templates or tools. So just a wealth of knowledge there.
And that's at www.myrounding.com. And then, Chad, if folks were interested in learning a little bit about interdisciplinary care coordination and the work that Huron does, where could they find that information?
Good question. Probably really the best thing to do is reach out to me directly. We do have obviously an internet site at Huron that you can contact me through that. But
and that's www.huronconsulting.
HuronConsultingGroup.com.
HuronConsultingGroup.com. And then Chad, do we have your? We've got info at MyRounding. So actually, if you do go to info@MyRounding, we would be happy to put you in contact with Chad if you've got some interest in some of the work that Huron is doing in that respect. Katie, do we have additional questions?
We do not currently.
All right.
Otherwise, if you are interested in getting these slides or a recording of this webinar, those are going to be available on our SlideShare page, which is slideshare.net/MyRounding.
So slideshare.net
/MyRounding.
/MyRounding. Slideshare.net/MyRounding.
That's on your screen right now, and I'm also going to send out a follow-up email that has the link to that as well.
Fantastic. Well, great. Well, without additional questions, thanks everyone for your time. We really appreciate it, and we wish you some happy multidisciplinary rounding.